There is a room that is meant to be a sanctuary of healing and trust, a place where we go in our moments of greatest vulnerability, seeking wisdom, compassion, and care. It is the doctor's examination room. For many of us, especially as we get older, the person in the white coat represents the pinnacle of knowledge, a trusted authority to whom we hand over the sacred responsibility for our own well-being. We enter this room with a sense of deference, with a lifetime of conditioning that has taught us to be the good patient, to not ask too many questions, to not take up too much time, and to accept the pronouncements from on high with quiet gratitude. The problem we are going to confront today is one of the most painful, uncomfortable, and critically important truths of our modern healthcare system. It is a truth that is almost never spoken aloud, a truth that operates in the subtle biases, the unconscious assumptions, and the systemic failures that can turn this supposed sanctuary into a place of profound and sometimes dangerous invalidation. The problem is that the way the medical system sees you, as a person over the age of 60, 70, or 80, is often fundamentally and dangerously flawed. What if I were to tell you that the dismissive pat on the knee you receive when you complain of a new ache or pain is not just a benign quirk of a busy doctor's personality, but is a symptom of a deep and pervasive ageism that is woven into the very fabric of medical training? What if the vague diagnosis of "it's just your age" is not a diagnosis at all, but an intellectual surrender, a failure to engage in the rigorous, investigative work that your health deserves? And what if the prescriptions you are given, the tests that are overlooked, and the symptoms that are ignored are all part of a larger systemic pattern that can have devastating, and in some cases, fatal consequences? Today, we are going to pull back the sterile curtain of the examination room and have a brutally honest and ultimately empowering conversation. We are going to reveal the 5 ugly, unspoken truths about what the medical system, and by extension, many of the doctors who work within it, really thinks about older patients. We will not be engaging in a session of doctor bashing. The vast majority of healthcare professionals are good, dedicated people who are working under immense pressure in a broken system. This is not about blaming the individual. It is about exposing the systemic biases and the intellectual blind spots that can lead even the best-intentioned doctor to provide suboptimal care to their older patients. We will dissect each of these 5 truths. We will explore the deep, psychological, and systemic reasons behind them, and most importantly, we will provide you with a clear, actionable, and life-affirming blueprint for how to become a powerful, effective, and respected advocate for your own health. This is your masterclass in how to navigate the healthcare system with your eyes wide open. It is your definitive guide to ensuring that you are not just seen as a collection of age-related symptoms, but as the unique, complex, and vital individual that you are. Before we dive into the first of our 5 ugly truths, we must establish a foundational understanding. The modern healthcare system is a marvel of acute care. If you have a heart attack, if you are in a serious car accident, if you have a burst appendix, there is no better place on earth to be. The system is designed for heroic, life-saving interventions in moments of crisis. However, it is profoundly, and often tragically, ill-equipped to deal with the complex, multifaceted, and chronic health challenges that are the hallmark of aging. It is a system designed for sprints, not for marathons. And this fundamental design flaw is the soil in which all of our 5 ugly truths take root. This brings us to the first, and perhaps most common and infuriating of our truths. Truth number 1, the pervasive and dangerous use of age as a diagnosis. You go to the doctor with a new and concerning symptom. Perhaps it's a persistent fatigue that has stolen your energy, a nagging joint pain that is limiting your mobility, or a subtle but frightening change in your memory. You explain your symptoms, and after a brief examination, you hear the 5 most dismissive words in all of medicine. "Well, what do you expect?" Followed by the inevitable conclusion, "It's just your age." Let me be absolutely clear. Age is not a diagnosis. It is a risk factor. It is a context. It is never, ever, a sufficient explanation for a new or worsening symptom. To accept age as a diagnosis is an act of profound intellectual laziness. It is a surrender. It is the doctor, consciously or unconsciously, saying, "I am not going to investigate this further because the decline of your body is a normal and expected event, and there is nothing to be done." This is a belief system that is deeply ingrained in medical culture, a form of therapeutic nihilism that is applied almost exclusively to older patients. A 40-year-old who presents with a new, debilitating fatigue will be given a comprehensive workup. An 80-year-old with the exact same symptom is often told to simply slow down. Let's dissect the profound danger of this mindset. That fatigue you are experiencing could be a sign of a thyroid disorder, AB12 deficiency, a low-grade infection, an undiagnosed heart condition, or even a side effect of a medication you are taking. That joint pain could be a sign of an inflammatory autoimmune condition like polymyalgia rheumatica, which is highly treatable. That memory change could be related to a vitamin deficiency, a sleep disorder, or a medication side effect, not the inexorable march of dementia. By accepting the non-diagnosis of "it's just your age," you are allowing a potentially treatable, and in some cases a completely reversible, condition to go uninvestigated and unmanaged. You are consenting to a lower quality of life based on a lazy and scientifically unfounded assumption. Why does this happen? It is a combination of factors. It is partly the time pressure of a 15-minute appointment, which does not allow for a deep, investigative dive. It is partly a lack of specific training in geriatric medicine, which teaches doctors to look for these atypical presentations of disease in older adults. But at its core, it is a form of unconscious ageism, a pervasive societal bias that views the decline and suffering of older people as normal and acceptable. So, what is the life-affirming and potentially life-saving response to this? You must, with politeness but with unwavering firmness, refuse to accept age as a diagnosis. When you are told, "it's just your age," your response must be a calm and respectful counterquestion. You can say, "I understand that these symptoms are more common as we get older, but I would like to explore what the specific underlying medical reason for my symptom is. What are the possible conditions that could be causing this fatigue? What are the specific tests we can run to rule them out?" You are not being a difficult patient. You are being an engaged and intelligent partner in your own healthcare. You are politely refusing to be dismissed. You are insisting on a real diagnosis because only a real diagnosis can lead to a real treatment. This leads us directly to our second ugly truth, which is the logical and dangerous consequence of the first. Truth number 2, the over-reliance on the prescription pad and the underutilization of diagnostic testing. The modern medical system, particularly in primary care, has become a system of rapid-fire symptom management, not of deep root cause investigation. The 15-minute appointment slot is simply not enough time to take a comprehensive history, to perform a thorough physical exam, and to engage in a thoughtful process of differential diagnosis. The path of least resistance, the quickest way to get the patient out of the door and to move on to the next one, is to write a prescription. You come in with joint pain. The fastest solution is a prescription for an anti-inflammatory drug. You come in with anxiety or poor sleep. The fastest solution is a prescription for a sedative or an antidepressant. You come in with high blood pressure or high cholesterol. The solution is a pill. This is what I call prescription-first medicine. It is a model that is focused on masking the symptom, not on understanding and addressing the underlying cause. And for an older adult, this model is a minefield of danger. The more medications you are on, a condition known as polypharmacy, the higher your risk of dangerous drug interactions, of adverse side effects, and of what is known as a prescribing cascade. This is a tragic and all too common scenario where the side effect of one drug is misinterpreted as a new medical condition, which is then treated with a second drug, whose side effect is then treated with a third drug. I have seen patients who have come to me on 10 or 15 different medications, where a careful deprescribing process reveals that the majority of their symptoms were, in fact, being caused by the very medications they were taking. At the same time that the prescription pad is being overutilized, the powerful tools of diagnostic testing are often being tragically underutilized in the senior population. There is a subtle, and sometimes not so subtle, bias in the system that questions the value of performing certain tests on an older person. There can be an underlying assumption that the results will likely not change the management, or that the patient is too old for a certain workup. Let's take the example of vitamin B12 deficiency. A B12 deficiency in an older adult can present with a devastating array of neurological and psychiatric symptoms. Memory loss that perfectly mimics Alzheimer's disease, a loss of balance and proprioception that leads to falls, a profound depression, and a debilitating fatigue. And yet, a simple, inexpensive blood test for B12 levels is not routinely performed on all older adults who present with these symptoms. The symptoms are too often dismissed as just old age. A similar story can be told for vitamin D deficiency, which is a primary cause of muscle weakness and falls, or for thyroid disorders, which can cause a host of nonspecific and confusing symptoms. The empowering solution is to become a proactive and inquisitive patient. You must not be a passive recipient of a prescription. When a doctor suggests a new medication, you have the right and the responsibility to ask a series of critical questions. You can ask, what is the specific underlying cause of this symptom that this medication is treating? Are there any non-pharmaceutical approaches, such as diet, exercise, or physical therapy, that we could try first or in conjunction with this? What are the most common side effects of this medication, and how will we monitor for them? And how will this new medication interact with the other medications I am already taking? And you must become an advocate for appropriate testing. If you are experiencing a new and unexplained symptom, especially a nonspecific one like fatigue or cognitive change, it is perfectly reasonable, and in fact, it is your right to ask your doctor, are there any basic nutritional deficiencies or hormonal imbalances that could be contributing to these symptoms? Would it be reasonable to check my vitamin B12, my vitamin D, and my thyroid function? You are not telling the doctor how to practice medicine. You are engaging in a collaborative dialogue. You are reminding them that you are interested in root causes, not just in symptom management. This brings us to our third, and perhaps most technically complex, ugly truth. Truth number 3, the failure to appreciate the unique pharmacology of the aging body. Even when a medication is truly necessary and appropriately prescribed, a profound and dangerous error can be made. The error is in the dosing. The fundamental principle of geriatric pharmacology is start low and go slow. The reason for this is that the body of an 80-year-old does not process and eliminate drugs in the same way as the body of a 40-year-old. As we age, several key physiological changes occur. First, we tend to have a higher percentage of body fat and a lower percentage of body water. Many drugs are fat-soluble, which means they can accumulate in the fatty tissues of an older person, leading to a much longer and more unpredictable duration of action. Second, as we have discussed, kidney function naturally declines. The kidneys are the primary route of elimination for the majority of drugs. A less efficient kidney means that a drug and its metabolites can stay in the bloodstream for a much longer period, building up to potentially toxic levels. Third, liver function can also decline. The liver is the primary site of drug metabolism, breaking down drugs into their active and inactive forms. A slower liver metabolism means that a standard dose of a drug can result in a much higher and more prolonged concentration in the blood. When you combine these factors, a different body composition, slower kidney function, and slower liver metabolism, the result is that a standard adult dose of many common medications can be a significant overdose for a person over the age of 75. This is not a theoretical concern. It is a daily reality in our hospitals and clinics. I have seen countless older patients who have been admitted to the hospital with a new and confusing set of symptoms, dizziness, confusion, falls, a sudden decline in function, where the ultimate diagnosis is not a new disease, but a simple and tragic case of drug toxicity from a medication that was prescribed at too high a dose. This danger is particularly acute with medications that have a narrow therapeutic index, meaning there is a very small window between a dose that is effective and a dose that is toxic. This includes drugs like digoxin for the heart, warfarin for blood thinning, and certain anti-seizure medications. Why does this happen? It happens because our healthcare system is still largely based on a one-size-fits-all model of medicine. The clinical trials that are used to determine the standard dosage of a new drug are often conducted on a population of younger, healthier adults. The unique physiological realities of the oldest old, those in their 80s and 90s, are often not well represented. A busy primary care doctor may simply not have the time or the specific geriatric training to perform the careful dose adjustments that are required. The empowering solution is to, once again, become a vigilant and proactive advocate. When you are prescribed a new medication, especially if you are over the age of 75, it is perfectly appropriate to have a conversation with your doctor and your pharmacist about the dose. You can ask, is this the standard adult dose? Or has it been adjusted for my age and my kidney function? Should we consider starting with a lower dose and slowly titrating up to find the lowest effective dose for me? You can also be a vigilant monitor of your own body. If you start a new medication and, in the days or weeks that follow, you begin to experience a new and unexplained set of symptoms, you must not dismiss it. You must consider the possibility that it is a side effect of the new drug, and you must report it to your doctor immediately. You are the world's leading expert on your own body. This leads us to our fourth ugly truth, which is a cultural and systemic issue that permeates all of medicine. Truth number 4, the invisibility and dismissal of the female patient. While ageism is a problem that affects all older adults, it is a sad and undeniable truth that this problem is often magnified for older women. There is a deep and historical bias in medicine that has long viewed the male body as the default human and the female body as a more complex and atypical variation. This has had profound and dangerous consequences. For centuries, medical research, and particularly cardiovascular research, was conducted almost exclusively on men. The classic Hollywood heart attack symptom of a crushing chest pain and a pain down the left arm is, in fact, the classic male symptom. We now know that women often experience a heart attack in a completely different way. Their symptoms can be much more subtle and nonspecific. A profound and sudden fatigue, shortness of breath, a pain in the jaw or the back, nausea, and a vague sense of anxiety. You can imagine what happens when an older woman presents to a busy emergency room with these atypical symptoms. They are far more likely than a man to be misdiagnosed. Their symptoms are more likely to be dismissed as anxiety, as indigestion, or as a panic attack. They are more likely to be sent home, only to have a major and potentially fatal cardiac event hours or days later. This is not a matter of opinion. It is a matter of statistical fact, documented in numerous medical studies. This bias extends beyond heart disease. Women are more likely to have their pain, particularly chronic pain, dismissed as being emotional or psychosomatic. They are more likely to experience adverse drug reactions, partly because the standard dosages were often determined based on the metabolism of an average-sized male. And the normal and sometimes challenging physiological transitions of a woman's life, particularly menopause, are often poorly understood and inadequately treated by a medical system that has not prioritized the study of female health. The solution to this deeply entrenched problem is a difficult one, but it is not an impossible one. It requires a combination of self-advocacy and a careful selection of your healthcare team. For older women, it is particularly important to find a primary care doctor who you feel truly listens to you, who does not dismiss your symptoms, and who has a demonstrated interest and expertise in women's health. You may need to interview several doctors before you find the right fit, and you must learn to trust your own intuition. If you are a woman, and you are experiencing a new and concerning symptom, and you feel that you are not being taken seriously, you must not back down. You have the right to a second opinion. You have the right to say, "I understand that my symptoms may be atypical, but I am very concerned that this could be my heart. I would like to have an EKG and a cardiac enzyme blood test." You are not being hysterical. You are being your own best advocate. You are fighting back against a century of systemic bias, and you are doing it for your life. This brings us to our fifth and final ugly truth, a truth that is perhaps the most difficult to hear, because it turns the mirror back on ourselves. Truth number 5, the patient's own role in the breakdown of the doctor-patient relationship. While the system is flawed and the biases are real, we, as patients, can sometimes inadvertently contribute to the very problems we are complaining about. We often enter the doctor's office completely unprepared. We have a vague sense of what is wrong, but we have not taken the time to organize our thoughts, to prioritize our concerns, or to prepare a clear and concise history. We present the doctor with a scattered and confusing narrative, and then we are surprised when we receive a scattered and unsatisfying response. We also often fall into one of two counterproductive roles. We are either the completely passive patient who asks no questions and accepts everything at face value, or we are the overly aggressive and demanding patient who comes in with a stack of internet printouts and a confrontational attitude, immediately putting the doctor on the defensive. Neither of these approaches is conducive to a healthy, collaborative partnership. The ultimate, empowering solution to all 5 of these ugly truths is to reject these old models and to embrace a new role for yourself. You must become the CEO of your own health, and your doctor is the expert consultant that you have hired to be on your board of directors. A good CEO does not just show up to a board meeting and hope for the best. A good CEO comes prepared. This means that before every single doctor's appointment, you will do your homework. You will take 15 minutes to sit down and write down a clear and concise list. At the top of the list will be your number 1 most important reason for this visit. Then you will list your 1 or 2 other concerns in order of priority. For each concern, you will write down a few bullet points. When did it start? What does it feel like? What makes it better? What makes it worse? You will also bring a complete and up-to-date list of all your medications, including any over-the-counter supplements you are taking. You will walk into that examination room not as a passive, supplicant patient, but as a well-prepared professional partner. You will hand your doctor your prepared list and say, "I have made a few notes to help us make the most of our time together." This single act will transform the entire dynamic of the visit. It will signal to your doctor that you are a serious, engaged, and organized patient. It will allow them to quickly and efficiently understand your concerns, and it will free up precious time for a more thoughtful discussion. And during that discussion, you will be a respectful but inquisitive collaborator. You will ask the questions we have discussed. You will seek to understand the why behind every recommendation. You will participate in a process of shared decision-making. This is the new model of patienthood. It is a model that is built on a foundation of mutual respect, of shared responsibility, and of a profound and unwavering commitment to your own well-being. Let us now step back and view the entire, complex, and ultimately hopeful landscape we have navigated. We have confronted the 5 ugly, unspoken truths that can so profoundly compromise the healthcare of older adults. The dismissal of our symptoms as just our age, the over-reliance on the prescription pad, the failure to adjust for our unique physiology, the systemic bias against the female patient, and our own unpreparedness. And for each of these truths, we have forged a powerful, proactive, and empowering solution. This is not a message of cynicism or despair. It is a message of profound realism and of radical empowerment. The healthcare system is not going to change overnight, but you can change, and your change can begin today. You can choose to no longer be a passive object in a flawed system. You can choose to become an active, intelligent, and respected subject, the true and undisputed author of your own health story. The path forward is not about finding a better doctor, although that is important. It is about becoming a better patient. It is about arming yourself with knowledge, with preparation, and with the unwavering conviction that your health, your vitality, and your life are worth fighting for with clarity, with dignity, and with an unshakable and profound respect for yourself.